Good afternoon, everyone. I hope you had a nice lunch. um, so, the purpose of our presentation today is to give the Assa membership an update of the work that the Assa COVID-19 team has been doing over the last 18 months or so. So we will touch on the structure of the team, the processes we have followed, our key findings, what we're currently working on, and the direction of our future travel. So in turn from the Assa membership, we will be looking at input and feedback on the work that we have been carrying out and our key findings. I will start, and then my team will give much more detailed information. So we have got a terms of reference that was approved by Assa Council. So in fact, if I can just go back a little bit, we are at phase 2 of this project. Phase 1 of the project, if most of you will remember, was led by Barry Charles. It was mostly to do with the modeling of the pandemic. Phase 2, which is where we are now, looks at the analysis of the impact of COVID, prospective and retrospective analysis. And it also looks at the market conduct issues and professional conduct issues that was encountered during the pandemic. So in other words, what did we do as a profession, as Assa? What could we have done, and what can we do if there was ever another pandemic like that? So this is phase 2, this is where we are. Phase 3, in terms of the direction of travel, is to say, we are particularly looking at COVID now, but can we be in a situation where we have got a committee that looks at future pandemics, not necessarily just COVID, but future pandemics. It is important for me to highlight that in terms of our terms of reference, this is a forum for all Assa members to discuss everything that is COVID related, to discuss, debate, and influence the actuarial profession in a positive and constructive way. That benefits us as a profession and the society at large. So again, I'll reiterate that it's a forum for all Assa members. It is not just for me and my team here. It is not for Assa Council. It is not for Council. It is for Assa members. That is why we are here. I'll not touch a lot on the objectives. You can see them on your screen. And this will be put on the Assa website for the membership to have a look. And again, we need your input on what extra we can do or feedback on what we have done. Sorry. In terms of the structure of the team, we split the team into 3, depending on our skill set. So the life and mortality work stream, that is led by KARSTEN. They have produced a paper that is included in the convention papers. Then the health work stream that is led by Adam. Again, we've produced a paper that is also in the convention paper. And then the market conduct work stream, which is led by SIEBERT. Again, we have produced a paper which is included in the convention papers. Now, then I've got Roseanne as well, who adds a lot of value from an international perspective. And so what we have done, although these work streams were working in their groups, for example, the life and mortality work stream worked very closely with LAC. Our reports have been seen and looked at by LAC. KARSTEN and team have had discussions with LAC. In terms of the healthcare work stream, we are lucky enough that Alex, who is the chair of the healthcare committee, is part of our team. And we have had discussions at the healthcare work stream, healthcare committee. In fact, Adam also, with our support, presented at the Assa healthcare sessional CPD day this year. So we have been working in conjunction with the main committees of Assa. I just wanted to acknowledge input from Assa Council representatives who are part of the team. So I'm talking about Neil. I don't know if Neil is around, and also Christoph. Thank you for your input on the team and being the link between us and Assa Council. Lusani as well was part of the team representing the Public Interest Governance Committee. And Lusani is a friend of mine and always asks the difficult questions, but I think we found each other along the way. I also want to acknowledge the fact that the Assa president and the president-elect attended some of our meetings, asked some questions, reviewed our reports. So I'm grateful to that as well. Last but not least, we have got a secretariat of the team that is Pumla, Zandi, and Tandanani. Just to say thank you to those guys. I don't know if they're in the crowd. They make my life easier in terms of setting up meetings, minutes, making sure they deal with membership issues, etc. I also want to point out that Pumla is a student on the committee, actuarial student still writing exams. So for those of you who think that the team is only for actuaries, that is not the case. If you are interested to join the team and you've got input to add to the team, and to be able to experience some of the best minds in the business, for students, I would really recommend that maybe not on this committee, but on any other committee that you are passionate about. It is the time to get involved in professional matters. So thank you, Pumla, for that, for being an example. Now, how did we come up with the membership of the committee? We had a workshop back in 2022. As I said, the first process or leg of the project was the one run by Barry Charles, which did very well. Most of you will remember that Barry got a presidential award for the modeling work that he did. I think I see Barry in the, if we can just give him a round of applause for the work that he did on the modeling work. So the membership came out of that. In quarter one of 2022, there were questions about what do we do? Do we stop the work that we are doing, or do we continue? And if we continue, what sort of work are we going to do? So that is where the terms of reference came, and the membership as well. I must say that the membership was extended by Assa to all practice areas. And the communication came from Assa to say whoever wanted to join the committee can join the committee. I must add that although you see a list of companies in front of you, membership and contribution to the task team is purely on a personal, professional capacity. So in other words, we do not necessarily represent our companies, but I put the companies there for you to have a feel of the diversity of the team in terms of the companies that we work for, in terms of the practice areas, and in terms of the sectors that we represent. That is very important because, as I said at the beginning, this is a forum for all Assa members. So we wanted this team to be representative of the Assa members. You can see there that there are large health insurance companies, large insurance companies, some of the biggest actuarial consulting firms, some big universities, etc., etc. So in our view, it was important to have that because then we can have a variety of data points, a variety of experience and input from different people with different experiences. Now, in front of you, you can see the key findings of the task team. Now, I'm not going to spend a lot of time on that. My team will then give more meat on these findings. But I wanted to say that in addition to the reports that we've made available, a lot of research was done by the team to come up to these conclusions. So in the reports, there is a lot of reference, a lot of research, so that has been made available on the convention page. However, I do understand that not many people would have read that, so I will make sure that the reports are on the Assa website under the COVID-19 task team. So you can have a read yourself. You can peer review, you can come up with comments, you can approach me and the team if there are any inputs on the reports. As I've said, the report were done by the team. We had an internal debate. After that, it was sent to council. Council had a thorough review of our reports. And as I said, we worked hand in hand with the healthcare committee and LAC, and we are still working in partnership with them to arrive at these conclusions. I'll quickly run through the conclusions and then my team will follow. Number one, we believe that COVID was a deadly pandemic in South Africa and globally. Number two, we believe that the deaths actually are underreported. Thanks to excess deaths, we are able to quantify that, but we actually think that even that is underreported. Point 3, 4, and 5 talks to the societal impact and the government interventions that they did to try and contain COVID. In our analysis, there were some unintended consequences, and the impact is difficult to quantify. So that is still a work in progress. In terms of number 6, we want to categorically say that based on the data that we have, vaccines save life. And that if we had vaccines earlier, we would have saved many of the lives that we lost, friends, relatives, colleagues, and the general population. And we want to say categorically, based on the evidence that we have, that the benefits of vaccines outweigh any risks of the vaccines. Number 7 says that the impact of COVID, we have felt it, but we believe that we're going to feel it for a few more years to come. And lastly, as actuaries, we want to say that we have a public interest and prudential role to help in understanding and mitigating the risks of pandemics like the COVID pandemic. And that's why, as a next leg, we want to put in place a body of evidence that will help us should there be any other pandemics in future. Thank you. I will pass on now to KARSTEN to report on the life and mortality workstream.
Thank you, Clayton. So, good afternoon, everyone. I'll be discussing the impact of COVID-19, especially the resulting mortality on the South African population as well as the life insurance industry. Then I'll go on to discuss our actuaries or our role as actuaries, insurers, and reinsurers. So this is a graph of the expected weekly deaths. It was modeled by the South African Medical Research Council in order to determine a baseline for excess deaths. The period most affected by COVID in terms of mortality was this period from April 2020 to April 2022. In a normal year, we would expect about 500,000 deaths, or in this period, just over 1 million. There was just over 100,000 COVID deaths reported in this period. Of course, the reporting process for COVID deaths wasn't perfect. So there were some differences between what we actually think can be attributed to COVID and what was reported. So these differences could be attributed to differences in classification, availability of tests, data collection issues, and also capacity constraints. In the same period, a total of 264,000 COVID deaths was reported. To date, that number has gone up to 340,000. So I want to draw your attention to 2 points here. Firstly, there was a massive amount of extra mortality burden in this period. In 2018, Stats SA released a publication that showed that 29% of our country's deaths come from communicable diseases. So this number almost matched that. Secondly, I forgot my point there. I'm sure I'll get it later on anyway. Okay, so, of course, that's it. So, it seems like COVID reported deaths were heavily underreported if we look at the expected deaths per week plus the COVID report deaths compared to the actual total deaths. So, looking at the reported deaths compared to the excess deaths. So that brings me to the question, are excess deaths caused by COVID? So firstly, if we look at this graph of positive test incidents compared to the spikes in total mortality, then you can easily see a high correlation between those two and consequently a high correlation between incidents and excess deaths. Secondly, there's also a high correlation between reported COVID deaths and excess deaths. So those are two different scales. Of course, the excess deaths were much higher. Of course, correlation doesn't imply causation. So we have to rationalize this problem. two obvious possible causes of these additional deaths come to mind. Firstly, COVID as a direct cause, and secondly, the shortage of healthcare that resulted in other illnesses causing higher deaths. So the Medical Research Council attempted to estimate the number of excess deaths that we can attribute to COVID, and at the time of writing this paper, they estimated it at between 85 and 95% of excess deaths. So what was the societal response? Social distancing, reduced size gatherings, and masks were all typical responses across the globe. In addition, alcohol restrictions and curfews were also imposed in South Africa. So as a collective, it was clear that these measures reduced the mobility in South Africa, and it was also shown that reduced mobility resulted in reduced spread and consequently reduced mortality. The overall impact of, the overall effect of this group of interventions is difficult to understand if you what would happen if you just take them away, because it's difficult in understanding the converse of the real world events. But it's clear that the immediate effect would have been very dire. So then, of course, the scramble for vaccines. So it's clear that if we could have had vaccines at an earlier point, then the ultimate mortality outcome would have been much less negative. Economic consequences are also very hard to study because it's difficult to study or to understand the converse of the real world events, similar to the measures above. So were these measures justified? It's a fair question given the uncertainty in what the converse would have been to the real world events, and also the widespread economic impact of the lockdowns. But there were to date 340,000 excess deaths, so I would say that one would err on the side of caution. What if we did more? If we could isolate more and reduce mobility even more, then spread would have been reduced and consequently mortality would have also been reduced. If we could have had vaccines at an earlier point, the same would have happened. If we look at this graph of total vaccinations compared to excess deaths, then you can see the effect of herd immunity later on in the pandemic. Of course, this would have been supplemented by natural immunity, but can't always wait for natural immunity. So I want you to imagine what would have happened to this graph of deaths if we could either have brought forward that immunity a bit or have delayed that that third wave a bit more. So what was the actuarial response? I'll go through this internationally and locally. So the IFOA established the COVID-19 Action Task Force as well as the Actuaries Response Group. They helped in understanding the effects of COVID-19. And similarly, Assa also established the COVID-19 task team and also helped to understand the effects of COVID-19 by producing a range of models or models that showed a range of outcomes. Then secondly, the Assa CSI COVID dashboard, and then also a guidance note that to help insurers consider all the relevant points, or most of them. So then some information bulletins were also produced by actuaries in various different positions, insurers, reinsurers, Assa, the IFOA, and other actuarial bodies. And lastly, we are, as an industry, reviewing our performance in the pandemic, as well as the performance of our capital regimes. Then what was our role as insurers? So this is a graph of the Assa CSI COVID dashboard. It shows the excess mortality in the individual new generation market compared to that of the population. So it's clear that insurers paid a significant amount of deaths. In the height of the pandemic, they paid almost 5 times what they would have expected in a normal month, compared to the population mortality at 2.5 times. So this, the phenomenon of this difference was explained in a presentation in last year's convention as well. Although the relative excess mortality compared to the expected is much higher for the insured population, the expected mortality for the general population is much higher. So the absolute excess death rate, mortality rate was still higher for the general population. Apart from paying massive amounts of claims, insurers also had to make various other changes in order to keep their shareholders and clients happy. Those consisted of premium holidays, pricing updates, claims practices and definition updates, underwriting practice updates, and changing risk assessment processes and shock scenarios. So of course, death cover was first in line for COVID, but other benefits also suffered or on the way to some worse experience. 7-day waiting period income protection took a massive blow in claims, especially for those that could not isolate, like healthcare practitioners. Critical illness and lump sum disability claims are expected to have had a reduction early on in the pandemic due to reduced accidents as well as reduced diagnosis. But those are expected to catch up for exactly the same reason. Now it's just delayed diagnosis. Also there was also reduced treatment in the times of lockdown, so that will also presumably result in higher claims in these benefits. Still waiting for industry data to be compiled for those. Of course, lump sum disability claims require a high level of disability, so the effect on those should be marginal. Then on to future mortality and morbidity impacts. There are still some excess deaths if we look at this graph a bit closer. So the general population is still tracking between 0 and 10%, and the insured population is still tracking between 10 and 20%. Now, the problem here is that we've lost sight of this baseline because it was determined using up until 2019 data. So that means that we can't know what part of the excess deaths later on in the pandemic can be attributed to COVID. So now the lingering question is this the new baseline? Some other impacts include delayed diagnosis and treatment, as I mentioned earlier, economic repercussions, accelerated deaths of impaired lives, and one positive point, medical technology advances. Now the future focus for our industry and also for this group. Firstly, we need to encourage Stats SA to release cause-based data so that we can understand the effects on mortality even better and more definitively say what portion of excess deaths are due to COVID. Then we need to support ongoing population-based data monitoring. This is in line with the global drive towards future pandemic readiness. Assumption setting for future pandemics will also be top of mind for many of us. Planning, we need to plan at a societal level for future pandemics. We've all felt our reliance on the global supply chain in this pandemic, for example, on vaccines and medical technology. Then we need to recalibrate our capital regimes and make sure that they are still up to date and accurate. And then lastly, we need to support ongoing studies and research on long COVID, pandemic modeling, as well as excess living benefit claims. Okay, then I'll give over to Adam for the healthcare part. Thank you very much.
Thanks, Karsten. My role here, I guess, is to summarize two things. There's a very brief section we've got on the medical scheme experience, which, as you'll see, differs slightly from the insurer's experience, but also to summarize some of the health/clinical literature and research of the pandemic. Those of you who were in the healthcare seminar that Clayton mentioned earlier in the year, you will have seen a lot of this before. There's some new stuff, but most of it is a repeat from there. Really, the goal of our work stream was to look at the health effects. We're talking more about morbidity than mortality. The first thing we looked at was to see how did the wave patterns develop in South Africa. And I've just used official counts here because excess deaths really falls into the realm of the other work stream, and we don't obviously have excess cases. But really the point here is to highlight that you've had different waves driven by different variants of the virus. There is epidemiological research that outlines the characteristics of the variants. And really what you can see is that the characteristics of the variants reflect in the waves. So you can see the first wave was driven by the original COVID virus form. There were no variants there. And while we thought it was a catastrophe at the time, it turned out to be a relatively mild wave compared to some of the later ones. The second wave in South Africa late in 2020, early in 2021, was driven by what was then known as the South African variant, what became known as the beta variant, which was theorized to be slightly more infectious than the original variant, but significantly more severe. And you can see that in the large peak of deaths in the beta wave. Then we had the third Delta wave, where Delta was theorized to be significantly more infectious than the original virus form and than beta, but less severe than beta, obviously more severe than the original virus form. And you can see that in the very large peak of cases. That's a signal of infectious, and the sort of sustained peak of deaths, but not at as high a level as the beta wave. Then the fourth and fifth waves was the Omicron variant. This is where it starts to get murky because the vaccination rollout was in full swing before that fourth wave started, but Omicron is theorized to be more mild in terms of severity, even though it's more infectious. And you can in a way see that in the data because the fourth wave had the highest peak of cases but the lowest peak of deaths. So it is, I guess the wave patterns in South Africa are consistent with the variants, or the theorized variants. And just to make a point, the variation theories aside, possibly from beta, the variation theories weren't derived off South African data. They were derived off global data. Second thing I want to point out is just, and this is the only slide I really have on medical schemes, is that in general, in spite of suffering a significant cost of COVID cases, the overall medical scheme experience was positive. Medical schemes paid fewer claims during the pandemic years, certainly in 2020 and 2021. We're seeing in some schemes a bounce back in 22 and 23. Other schemes are sort of back to their long-term baseline. The point really was a healthcare facility was not a place where anyone wanted to be during lockdown and during COVID waves, because the likelihood of you catching the virus at a healthcare facility was a lot higher than the likelihood of catching the virus if you stayed at home. So it meant that a lot of non-essential medical treatment was postponed. And in fact, we saw hospitals cancelling elective surgeries or delaying elective surgeries in order to make provision, make space for COVID cases and COVID beds in their facilities. So medical schemes, and you've started to see some of this with the increases that have been released in the last couple of weeks, medical schemes are figuring out how they catch up and how they bounce back from COVID and what their post-COVID reality looks like. And it certainly across our base is very different for different schemes. The next one really was, and this is very much credit to Barry's work. Clayton mentioned the pivotal role that Barry played in the original COVID task team, and he actually wrote up this vaccine rollout, these acts that we use. And really, I don't think anyone wants to be reminded of the scramble we had in 2021. I don't think anyone wants to go back to that period of history, but what we saw was this Medical Emergency Act 1. The priority was to secure and lock down the healthcare system so that the system was resilient, and when this big wave of Delta cases that we expected hit us, the system was able to cope with it. And the priority in that case was to find vaccines for healthcare workers. That one had a bit of a stuttery start. Those of you who are close to COVID like I am will remember that we procured 1 million Covishield, which were a variant of the AstraZeneca vaccine from the Serum Institute in India, which were proven then not to work against the beta variant, so we sent them back to India. Then we had a wave of the Delta variant against which the Covishield vaccines were proven to work. So it all was a bit of a stuttery start. But we did start getting Johnson & Johnson vaccines into the country, and we had the Sisonke trial where we vaccinated nearly 500,000 healthcare workers in a period of 6 weeks. We were fortunate that happened before the third wave because it meant the system was much more resilient than it could have been, and the Sisonke trial results really did prove that. Just a point, I haven't got references in my slides, but if anyone reads the paper that Clayton made reference to, all the links, all the data, all the studies that underlie this are linked in that paper. Once we got over the Sisonke trial and once we got over our bit of a false start, we started to get large stocks of Pfizer vaccines into the country, and we prioritized the highest risk group. You saw the previous presenter put up the case fatality rate for the over 70s. They were the group that was first prioritized. And those Pfizer vaccines started to come in numbers. Then they became supplemented by more Pfizer vaccines and by the Johnson & Johnson vaccines coming into the country. And then really that rollout built a lot of pace. Those of you who were in the sort of adult age bands between 30 and 60 will remember probably, you might not want to remember, but you probably do, that often we expected to be vaccinated at a certain date, and then they would bring it forward because the rollout was going, or the number of vaccines that had come into the country were faster than they expected. Then we had this Act 4 race to the finish where we were trying to reach, I've heard it variously referred to as herd immunity and population immunity. It amounts to the same thing. But having a significant amount of immunity in our population such that we mitigate the spread of the virus. And really that was about how do we deal with children? Do they get 2 doses or 1 dose? How do we deal with far-flung areas where it's difficult to access vaccines? How do we deal with the growing sentiment of people who didn't want to be vaccinated and things like that? And we seem to have come to population immunity probably faster than anyone thought. So this phase lasted, I guess, a little bit shorter than we all expected. You can anecdotally still get a COVID vaccine in South Africa, including a booster, but I think you've got to try quite hard to find one at the moment. It seems that phase has kind of passed. The next couple of slides really just summarize the vaccine research. And I think the point is there's significant academic research that shows some of these things. To the point that my co-presenter made in the floor in the previous presentation, the intention of the vaccine was to protect against severe illness and death. Any effects on transmission, anything outside of that, was really a fortunate coincidence, a bit serendipitous. But what we found when we looked at the research, and I'll show you some of the efficacy research on the next slide, but almost all studies found a significant positive effect on severe disease and death. The results were a bit more mixed when it came to transmission, not unexpectedly given the purpose of the vaccines. When studies looked at the duration of immunity, immunity does wane after you have a vaccine. The period is still debatable, but the consensus seemed to be moving towards a period of 4 to 6 months, which is why we had booster vaccine campaigns after the first round of vaccinations, because it was felt that we needed to top up that immunity while the virus was still circulating. Some, like me, expect there might be ongoing boosters for high-risk groups, but it hasn't been mentioned just yet. From a side effect point of view, and Roseanne will show some of the international experience when we get there, there were some side effects that were reported, but two points. Number one, the benefits in terms of severity and death seem to outweigh, certainly in the literature that we saw, seem to outweigh the effect of the side effects. And secondly, the side effects of the vaccine were significantly, or seemed to be significantly less problematic than the side effects of being infected with the virus. There was a specific risk for a while which caused a bit of a scare with the vaccine rollout, was this risk around myocarditis in younger males. Yes, it's there, yes, it's a real risk, but relative to the benefits, it was found to be comparatively small. I'm not meaning to understate the importance of this and the fact that we found it, but compared to the benefits of the vaccination rollout, it was relatively small. The last point I want to make is just on natural immunity, and before I talk too much about natural immunity, Karsten did mention it as well. Natural immunity, for those who don't know or have blocked it out because it was a traumatic period, is immunity that you get from having had the virus and recovered. And I think the point here is natural immunity works. People who've had the virus before tend to be protected from transmission and severity, but you have to have gone through the period of having the virus to get natural immunity, and that's, I'm sure most people, given a choice, would rather not have had the virus to start with. And then when we wrote the paper, it was still emerging, but what's happened since then is that research suggests that this what they call hybrid immunity is the strongest immunity. Someone who has had COVID and then has been vaccinated as well. The vaccine and the virus seem to produce slightly different immune responses which complement each other. And I think the research was 99% effective, this hybrid immunity. So it was a very interesting point, because the argument was whether people who had COVID needed to be vaccinated. And this hybrid immunity point did come through quite strongly. I'm not going to go through all of them, but the next is just I summarized all of the vaccination studies we could find. And I'll admit now we haven't found all of them. Obviously, people work in part-time, they work as they've got time, but we found over 200 papers, so it's not a small sample. And this really just explains the reasons why we've used the language we did in the papers. So if you look at the right block, which is the effect on severity, there were 4 studies out of over 100 in our set that found no effect on severity. 2 of those were in very immunocompromised or very sick populations. One was in people with multiple sclerosis, and one was in people who had had an organ transplant. The other one had a very small sample size, and there was one other that I couldn't find a lot of detail on. For transmission, it was a bit more mixed. There were about 10% of studies that found no effect, so no significant effect either way. There was one study that said vaccination increased transmission. I think, and I can't recall correctly, I can come back with the detail, but I think it was vaccinated members who got sick had increased viral shedding relative to non-vaccinated, vaccinated people who got sick. But the reason why we've used the language of it being a bit mixed for transmission is because there is yes, it's a minority, but there is a set of studies that show the opposite effect. This other research is really other research in South Africa. Roseanne will cover the international point of view. This is research that's done either by members of the task team in their employed capacity or by the employers of members of the task team, which is why Clayton put up the slide showing all the organizations that have contributed, and a lot of them have contributed to this. There was an analysis done of age and disease rates, mortality and morbidity, which really just confirmed, I think, what we probably all knew, that the age-based rollout was a sensible thing to do. There was also a cost-benefit analysis into the proposal to vaccinate the entire adult population as opposed to only high-risk groups, and that came out that there was still a benefit to vaccinating the entire adult population. Then there were a couple of very interesting sort of peripheral or additional studies that we found, one was around these pulse oximeters, and they created quite a lot of headlines during the pandemic. What these oximeters do is they allow you to monitor your oxygen saturation at home. A lot of the people who became severely ill with COVID was because their oxygen saturation dropped. The oximeter allows you to monitor your saturation at home and present it at a healthcare facility before it gets critical. And that was found to have a significant reduction in mortality because people were able to present earlier. Then the vaccine effects were enhanced if you were physically active, which was an interesting finding. And then the last one was more of a discussion around this endemic phase of COVID, which we seem to be in or seem to have been in for a little while now. And we probably won't spend too much time on that. The future work of our work stream is really we focus pretty much on academic research and on what we can find up to this point from the literature. What we want to do is to get medical scheme data and to look at whether we can replicate those findings on the ground, i.e., are we seeing in South Africa using the medical scheme data what we expect? And you can see some of the research questions we're looking at on the slide there. They cover a broad range of areas. I know we've taken on a very ambitious task, but hopefully we can at least accomplish a significant chunk of it. With that, and with thanks to the members of my workstream and the task team, I'm going to hand over to SIEBERT to talk about market conduct.
Thanks, Adam. The market conduct workstream was established to identify issues during the pandemic which may negatively affect policyholders or bring the profession into disrepute. This was broken down into issues ranging from TCF, professionalism of actuaries, and the profession as a whole in meeting its public interest responsibilities. The workstream started by considering key areas of actuarial work. During the pandemic, indicative market conduct risk ratings were debated for each area with recommendations to the profession through the relevant Assa structures. As with any complex actuarial problem, we found that the answers usually start with, "It depends." As a result, the work is framed purely as a reference point for further discussion and debate, considering possible lessons that can be learned with the benefit of hindsight. Actuaries have been involved in a range of critical areas over the past few years. They've faced unprecedented challenges, but also displayed remarkable resilience and innovation. Several key topics were at the forefront of these efforts. Pandemic modeling played a crucial role in guiding decision-making. It enabled actuaries to demonstrate the impact of various scenarios, helping to develop strategies to safeguard businesses, to protect clients, and in the public interest. Capital and liquidity management have been essential in maintaining financial stability. By carefully managing available resources, companies could meet commitments to clients even in the face of economic uncertainty. Recognizing the economic hardships faced by many, actuaries were involved in taking proactive steps to manage premium affordability. This included revisiting pricing structures and offering more flexible payment options to ease the financial burden on the clients. During these challenging times, actuaries continue to innovate, creating products and services that cater to the evolving needs of clients. Actuaries developed recommendations to assist clients by delaying medical aid contribution increases and finding innovative and sustainable ways of returning excess reserves. Actuaries were involved in enabling and optimizing operational processes like claims and underwriting during lockdowns by embracing digitalization. This has not only improved the customer experience, but also empowered employees to work more effectively in remote settings. However, actuaries were also involved in many difficult decisions with various degrees of market conduct risk. Issues around underwriting practices, client communication, and the public perception kept coming up during our discussions, and I'll address these in turn. Underwriting practices had to be adapted to allow for the impact of the virus on mortality and morbidity rates. Vaccination status, and recent infection were being introduced into underwriting questions, which attracted a fair bit of media attention and mixed reactions from the public. The workstream considered the Insurance Act, PPRs, TCF, the Promotion of Equality and Prevention of Unfair Discrimination Act, and ethical frameworks proposed by Assa members. There were no regulatory, ethical, or fairness barriers identified in using vaccination status or past infection as a rating factor in life insurance underwriting. In the workstream's opinion, it's up to individual insurers to decide if these factors should be included in their underwriting processes. However, care needs to be taken to ensure that any distinctions between these premiums and benefits are actuarially justified, not only at the underwriting stage, but also over time. For example, if there's a change in how vaccination status or past infection affects claims, loadings for these lives should be reconsidered. As a result, underwriting practices were allocated a medium market conduct risk rating. The importance of good communication became very clear during the pandemic. Actuaries were not only involved in drafting or reviewing new client communication, but also interpreting past communication and policy exclusions that were written many years before. Without being close to the technical detail or legal arguments, it appeared from the outside that some products in the market did not always provide the cover that a layperson might have expected during the pandemic. For example, business interruption claims, repudiations made headlines, with policy wordings being challenged in court. Similarly, the Ombudsman for Long-Term Insurance reported that credit life benefits made up 36% of COVID-19 and lockdown-related complaints, compared to only 9% of other complaints, likely due to the economic environment and that these are typically more disputable claims. As a result, we were reminded as a workstream how important it is for actuaries not only to consider the risks that are covered by a product, but also those that are being excluded. This will be important in identifying gaps in cover to improve product design, but also to clarify any excluded risks in communication so that clients are very clear what they are being covered for. Given the highly publicized nature of claims repudiation, client communication was allocated a high market conduct risk rating. The workstream recommends that more work is done in the different practice areas relating to client communication so that lessons learned can be shared with the rest of the profession. Actuaries do not only have a responsibility to employers and clients, but also to act in the public interest. Assa provided significant input behind the scenes through involvement with Business for South Africa and issued a number of media statements. The workstream considered public perception of companies, actuaries in the public eye, and the profession as a whole. Given Assa's prominent role and expertise, the workstream debated if it may have been beneficial to consider a more active role in public debate, especially going forward. A number of actuaries in South Africa and the UK who played relatively public roles during the pandemic were approached for input. This prompted a series of questions which may be used to set guidelines on how to respond to future pandemics or states of disaster. Some of these questions include: where can actuaries add significant value in the public domain? Should we be advising policymakers or rather be a technical resource upon which they may draw as necessary? How do we balance our professional obligation to act in the public interest with the need to manage our own reputational risk? Can we be more organized in terms of capacity and resources like working groups, and should these resources inform a formal Assa stance? The public perception of the profession has been allocated a medium market conduct risk rating, given the deliberately conservative approach taken by Assa during the pandemic. The workstream's view is that there could have been potential to have a bigger positive impact in the public domain, although this would introduce additional risk. It's recommended that the profession consider these questions in the context of the next pandemic. For the profession to act in the public interest, we need data. The workstream considered collaboration during the pandemic through various Assa structures. For example, the COVID-19 task team worked together by sharing analysis and developments to assist the profession in responding to COVID-19. Similarly, the gathering of mortality and exposure data on a monthly basis was done as part of CSI initiatives. Despite all of this being done in the public interest, the ongoing Competition Commission investigation into life insurance companies introduces uncertainty in terms of what information may or may not be shared. The workstream understands that Council intends to engage with the Competition Commission after the investigation is completed, which may assist in formalizing professional guidance to be followed by actuaries and the various Assa structures when sharing information. As a result, information sharing in the industry has been allocated a medium market conduct risk rating. Overall, no major market conduct concerns have been identified relating to COVID-19, given the need to balance solvency and consumer interests, although ongoing discussions and engagement remain necessary. The challenges posed by the pandemic have tested actuaries in many ways. As we move forward, let us continue to learn from these experiences, ensuring that we emerge stronger and more prepared for whatever the future may bring. Roseanne will now share some further thoughts, including an international perspective.
Thanks, Siebert. The Actuarial Society has always promoted, the principle that by providing platforms for sharing research, knowledge, and learning grows. South African actuaries have made valuable contributions to the global body of published research on COVID-19 during the pandemic and are continuing to do so. One of the first publications was on how using the Resilience Index enabled the identification of high-risk patients and saved lives during the first wave in South Africa. This was followed by many real-world vaccine studies on effectiveness in South Africa and abroad, and included a publication in The Lancet. These showed that being vaccinated conferred significant protection against serious illness and death during the Beta and Delta variants, and also that those who had survived a COVID-19 infection and then became fully vaccinated, the so-called hybrid immunity, seemed to gain the highest level of protection from future admission risk. Over December of 2021 and early in 2022, the highly transmissible Omicron variant replaced the formerly dominant Delta variant and drove an exponential rise in COVID-19 cases in South Africa's fourth wave. South African actuaries were involved in the publication of one of the first real-world studies on vaccine effectiveness against Omicron, which was published in the New England Journal of Medicine, and also flagged the need for regular vaccine boosting. There's clearly great public health value in sharing these insights as they become available and are validated through a rigorous peer review process. A concern related to vaccinations was complications, and of course it was important that the analysis considered this too. The real-world analysis showed here tracked 179 conditions and found that only 3 were identified as adverse events linked to COVID-19 vaccinations. All of these were mild in nature, causing treatable symptoms like swollen lymph nodes, inflammation in the muscle locally, and numbness. Whereas the adverse events linked to COVID-19 infection included pulmonary embolism, myocarditis, acute kidney injury, amongst many others, and of course, mortality, much more severe in nature. Analysis of mortality against in the medical scheme's lives showed that mortality reached a historic high on a crude mortality measure basis, in the top graph there, during the pandemic's second year, and tracked the waves of the pandemic. Also, that death rates have returned to near pre-pandemic levels. The analysis also shows that males have remained with an increased risk of death even in 2022 compared to the pre-pandemic death rates. The adjustments to crude mortality rates, allowing for age and sex, is key to any such analysis, and also shows that after allowing for the deteriorating medical scheme profile over the period from 2010, there's actually an overall downward trend in mortality when the COVID effect is removed. A large-scale study of COVID-19's impact showed decreased use of healthcare facilities generally, but particularly for some forms of cancer screening. These findings add to the growing body of knowledge of work that suggests that COVID-19 healthcare disruptions may have important but unknown as yet effects on disease outcomes going forward. And ongoing research will be monitoring these trends. What I've highlighted on the slide here is just showing that with cervical cancer diagnosis, the pattern of stage at the time of diagnosis has not yet reverted to pre-pandemic levels. Across the world, the actuarial profession has been involved in modeling, analysis of the COVID stats as they've emerged. The International Actuarial Association, of which I was the president last year, set up a pandemic task force in 2022 to bring together the work done by actuaries across the world and across the various member associations. This enabled us to compare notes and key learnings for pandemic preparedness going forward. You can see the range of countries represented on the task force, of course, including South Africa. The first paper that the task force has been working on is Lessons Learned from the Pandemic, and this should be published in the next few weeks. The paper aims to document the experience across various areas of practice and across various regions, and compare COVID pandemic experience to previous pandemics as well. This will enable actuaries to contribute to global conversations with supranational organizations like the OECD and the International Association of Insurance Supervisors about these key learnings and protection gaps and alternative ways to carry risk to protect vulnerable groups. These are all topics of global significance and importance. I've highlighted here 5 key learnings from the paper that you'll hopefully be able to read in detail in the next few weeks. The first one is on data and modeling, noting that actuaries are used to making use and sense of disparate data, but this is necessary at a heightened level during a pandemic and requires us to discern which metrics and which data sources are reliable and comparable. The second one is on collaboration and communication, as actuaries need to work with other professionals for an optimal approach. The COVID-19 response group in the UK, for example, made effective use of social media for sharing analysis and also addressing misinformation. The third one is on professional practice, where actuaries need to balance the need for rapid response against complying with the rigorous standards of our profession and ensuring that results are reliable. And where there is doubt or risk, conveying this appropriately. We need to be thinking about how our professional standards can accommodate this. The fourth one is recognizing that a resilient health system is key to pandemic preparedness, along with ensuring that we have the data systems and public health interventions to mitigate emerging pandemic risk. Actuarial expertise can meaningfully contribute as part of multidisciplinary teams to contribute to building these metrics and making sure that we have adequate financial risk protection tools. Finally, the fifth one is around risk management more broadly, where the interactions between pandemic risk and other areas of risk, such as fiscal constraints, climate change, and energy risk, can cause multiplier effects, as we've seen on steroids here in South Africa, that require robust scenario planning. All of these learnings are applied across various areas of practice to make this paper relevant to the profession broadly and not just to those working in healthcare. The Pandemic Task Force of the IAA is now also looking at a more detailed technical paper on COVID modeling and also on protection gaps. That it's become apparent that there are many protection gaps and many vulnerable groups that need additional or alternative ways of carrying risk. These topics are of particular interest for regulators and insurance supervisors, as I highlighted, and also for actuaries working in smaller markets who don't necessarily have the same resources and can benefit from these learnings. Further work is also considering how various financial institutions can build their resilience in terms of pandemic preparedness, and how the actuarial profession can contribute to addressing inequalities and access to treatment globally. So finally, from my side, a few comments on how we can ensure that we are professional in our approach to rapidly emerging risks, such as the COVID pandemic. There have been many areas for debate that have arisen over the past 3 years, and which we have been deliberating on in the Assa task team. Just considering these 8 topics and different views on these, there are over 40,000 possible combinations of views and opinions. Attempts to try and characterize these debates as binary, i.e. there's just 2 sides, are political and unhelpful. Labeling actuaries who are concerned about the emerging risks as lockdown apologists, or taking a strong initial view that is unshaken by emerging evidence, is not how a profession driven by protecting the public interest should work. We need to contemplate how we ensure that we're led by the data and not by our preconceived positions. So what's next for the task team? We're continuing with collaboration and sharing research with a focus on how Assa can contribute to the area of pandemic preparedness, building on our local and international partnerships. So let me leave you with the key points from the task team's work thus far that Clayton set out at the beginning, and which we'd appreciate your comments and some discussion. And let me end also by thanking everyone who's been part of this, and particularly to Clayton and Lou Rousseau, who are leading the task team at the moment. I have certainly felt that this is what being part of a collective actuarial community is about, and I continue to be inspired by the dedication and passion of my colleagues in this profession, who continue to demonstrate that it is the robust but respectful discussions that drive impactful contributions. Thank you.
Thank you so much to our team for taking us through that very insightful presentation. We unfortunately do not have time to extend the dialogue and to the audience for questions. However, you all still have an opportunity to reach out to our speakers via the connections function on the app. Thank you so much to our speakers. You're welcome to leave the stage.
So next up, we have a refreshment break preceded by the Liberty Mindfulness session, if you would like to take a pause before the break. And if you enjoyed the nail-biting chess semi-final in our first refreshment break, or you happen to miss it, then remember to pop by the chess tournament area in the exhibition hall for the second semi-final showdown in our inaugural Insights Assa Convention chess tournament. Also, do remember to go and take your picture at the mosaic wall so that we can have a visual representation of this historic convention.
Also remember to visit our other exhibitors this year who have so much more new on display. We have the Discovery Working Lounge, the Assa Hub, the Meeting Pods. A new addition this year, we have coffee bars that are also brought to you by Discovery, Hanover Re, Milliman, Old Mutual, RGA, and SA3, and I know I don't have to convince you to visit them. So we'll see you soon for the next session. Thank you.